Hi everyone, welcome to today's webinar, Building a Racial Equity Approach to Full Service Partnerships, also known as FSPs. This webinar is a part of the Multi-County FSP Innovation Project, as well as the LA County Department of Mental Health FSP Transformation. It's also the second in a two-part webinar series, and you can find the first webinar recording and materials on our website. My name is Aurel Amram, and I'm a director with Third Sector. We have a wonderful group of people here today with us who we will be hearing from. For the main part of the presentation, we have Maria Laurenti Foresti from San Mateo, Julie Leong from Sacramento, Dr. Jonathan Sheeran from LA County, Christopher Dirks from Kaminar's FSP program in San Mateo, and we'll be watching a pre-recorded video from an FSP client in Sacramento County. We also have additional perspectives we're really excited to hear from on the response panel for the last hour of this presentation, and that'll include a variety of voices, including Dr. Dante Early from the MHS-OAC. Zach, if you want to flip to the next slide. I'll spend just the first few minutes here introducing the projects so that we're all on the same page about the background of the work, a little bit more about why we're here today and what the projects have been working towards. I'll then turn it over to Sacramento, San Mateo, and LA counties to share a bit about their innovative and collaborative efforts to improve equity in FSP programs. We'll also at that time hear the provider and consumer perspectives on FSP programs. And then we hope to really leave the last hour for a little bit more interactive discussion. We have about 30 minutes for the response panel, and then 30 minutes for public question and answer. And we really hope to leave a lot of time to hear from you all and what's on your mind and answer any questions you have. So feel free to drop questions as they come to your mind in the Q&A box. If you scroll down to the bottom of your Zoom screen, you'll see a little Q&A button. Feel free to chat in any question on your mind throughout the presentation. We'll be monitoring that throughout, and we'll try to answer as many of them as possible in that last 30 minutes. And that'll be our plan for today. Great, thank you, Zach. Yeah, if you don't mind flipping to the next slide. I'll just share a little bit about who we are and what an outcomes orientation is. So Third Sector is a 501c3 nonprofit organization, and we partner with government and communities to help focus services on outcomes. We work with mental and behavioral health agencies across the state of California, as well as social service agencies across the country, partnering with communities to help focus services on outcomes. Our work on both the Innovation Project and with the LA County Department of Mental Health has supported FSP programs in taking this outcomes-oriented approach, keeping really improving outcomes as well as reducing disparities and increasing the equity of outcomes at the center of program design. And that includes building innovative funding approaches to provide the flexibility to do whatever it takes and understand what is and isn't working, using data over time to improve program design and make those policy and funding decisions. And really importantly, building a culture of continuous improvement, working with the community to hear feedback, look at data collaboratively, and continue to drive those improved outcomes and reduce disparities. Zach, if you don't mind flipping to the next slide. We've taken this approach partnering with the LA County Department of Mental Health since 2018, as you'll hear more about later today. They have taken a groundbreaking approach to bring this outcomes orientation to their full service partnership contracts and services. And that's included a focus on relentless engagement, building a team-based service model, redesigning funding and incentives, and creating improved data tracking and collecting, as well as continuous improvement systems. And we're really excited for that transformation to move forward this summer, and you'll hear a lot more about it later in the presentation. That groundbreaking FSP transformation inspired 6 other California counties to come together via the Multi-County FSP Innovation Project, which is a part of the presentation today. Fresno, Sacramento, San Bernardino, San Mateo, Siskiyou, and Ventura counties have come together with support from Third Sector, the RAND Corporation providing evaluation support, Palmesa as the fiscal intermediary, and the Commission to take the same work that LA County has done and think about how to apply it really statewide to a variety of diverse counties and geographies, and make adjustments and build for their local context an outcomes-oriented, data-driven FSP program. Counties are in the middle of a 12-month implementation period right now, where they're working both collectively and locally to clarify FSP eligibility, service, and graduation guidelines, improve data collection and measurement strategies, defining shared outcomes and metrics, and build a statewide vision for continuous improvement in full service partnership programs so we can continue to drive equitable and improved outcomes. And you'll be hearing again a little bit more about that project later on, but we hope that these new strategies will be piloted and launched by fall 2021, so in about 6 months. With that bit of background, I will now turn it over to the counties so we can hear from them directly. Zach, if you don't mind flipping to the next slide. San Mateo is up next, who is going to share a little bit more about their innovative efforts to provide culturally responsive FSP services.
Good morning. My name is Maria Lorente Foresti, and I'm the director of the San Mateo County Behavioral Health and Recovery Services Office of Diversity and Equity. I'm happy to let you all know how our office has applied a system-wide approach to improving equity with planned improvements in data-driven decision-making. I'd like to start by giving you a little history. In the spring of 2017, our office began its theory of change process as a critical step to creating a shared understanding of how various activities contribute to the long-term goals and success of our BHRS efforts to promote equity, cultural humility, and inclusion. By investing in this process led to the development of the 4 pathways that you see here, and is based on the belief that our overall system needs to address inequities where individuals, institutions, and structural biases are addressed, that lived experience matters and is valued, that advancing health equity is a key strategy to the prevention of mental health and substance use issues, and that a value-based approach centering cultural humility, inclusion, social justice, community collaboration, and focus on wellness, recovery, and resiliency are necessary. In sum, San Mateo County's approach to equity has been primarily at a systemic level with some program-specific efforts via our cultural competence plan requirements and analysis and the supports given to our partnering agencies. Systemic efforts to support equity work are via the Office of Diversity and Equity, which oversee the following BHRS activities. The first pathway, as you see here, is workforce development and training, which supports our work by ensuring the application of an equity lens to all trainings and professional development opportunities offered to staff and contractors, in addition to robust one-on-one support to promote cultural humility and inclusiveness efforts. An example of this in our work can be seen through our partnering agencies, such as Kaminar, who will be presenting shortly. Here, Kaminar hosted a Cultural Humility Day for their workforce. In this effort, all staff were trained in both cultural humility and sexual orientation gender identity training, or SOGI. This pathway can also be highlighted in another example, when our partnering agencies, which included the Latino Commission, Kaminar, Legal Counsel, and others, came together to create supports for our field-based workers who were concerned about the possibility of ICE presenting themselves when staff were with clients. This work assisted our providers in San Mateo County learning how to best support our clients and guide them during these possible interactions. This work also helped those we serve to be informed and know that we're supporting their wellness. The second pathway identified by our community, stakeholders, and workforce is organizational policies. Here, institutional change has moved across agencies that touch our behavioral health clients. We currently advance these practices via our cultural competency plan requirements of contractors and our cultural humility and inclusion policies, just to name a couple. Another example of this pathway at work was seen when we had a transgender client reach out to us about concerns in obtaining shelter. By listening to the consumer's experience, we were able to identify the need for grievance policy trainings or refreshers, the addition of a welcoming policy requirement as part of our cultural competency plans, and SOGI training for all of our BHRS interpreters. The third pathway is our strategic partnership. Here, the advancement of racial equity is lifted through the Diversity and Equity Council, previously known as our Cultural Competence Committee, and our health equity initiatives that are composed of staff, partnering agencies, clients, and community members. We see the active aspects of the pathway in our FSP providers and clients participating regularly in events, initiatives, and our Diversity and Equity Council. Through this avenue, we have been fortunate to have our FSP clients support our work. One example is the client who supports our annual San Mateo County Pride celebration. In speaking with this individual during and after their participation, they conveyed feeling happy that they were part of something exciting and enjoyed being with others. They also shared how helping others helped them feel better. These partnerships make a difference, and I believe may be one of our most valuable resources. The last pathway is community empowerment. Here we see programming to support engagement in decision-making and capacity building for clients and community in partnership with our Office of Consumer and Family Affairs, the Lived Experience Academy, and the Health Ambassador, just to name a few. This avenue also includes our stigma reduction work and recovery work, such as digital storytelling and photo voice programs. We have seen how these programs have assisted our FSP clients in various ways as well. One example was an FSP client that took our parent project class on 3 different occasions. This course is 12 weeks and requires weekly participation. This commitment to learn and gain more skills in parenting was inspiring, and she ultimately took the skills she learned to advocate for her son when he was struggling after starting a new school. She also became more confident in her abilities to share her thoughts and her voice. Next slide. I also want to share with you all our community-informed, culturally responsive improvement process. This process was developed for making culturally responsive improvements to our system. It is intended to reinforce the role of the Diversity and Equity Council and more meaningfully embed them in a feedback loop with our Quality Improvement Committee. The exchange of information, as you can see here, between our Diversity and Equity Council, the Quality Improvement Committee, our Health Equity Initiatives, and the Director will lead to cultural competence going beyond compliance and towards institutional transformation and continuous quality improvements of service. This process allows us to have many doors for our clients, community, and family members to share any barriers or challenge they experience. This process then leads to our office working with our Quality Improvement Committee and our Office of Consumer and Family Affairs to address issues systemically and comprehensively. For example, one example actually of how this process worked was when we received the complaint from the transgender client that I mentioned earlier. The individual was receiving support at our San Mateo County Pride Center. The individual reported struggling to find shelter due to their gender identity and due to Spanish being their primary language. Hearing from the client, having listening sessions to support the client and provider agencies led to understanding the gap in care where our shelters needed to provide a more welcoming environment and space for this individual to be able to stay in a residence where they felt safe and seen. Reaching out to the shelters and learning about their intake processes and ensuring that SOGI questions were asked and that individuals' requests for male or female dorms was being recognized and honored was important. Additionally, this process led to training on engaging interpreter services and grievance policy training for staff. In this example, the built-in communication led to support policy and system change to ensure that all were welcomed, respected, and felt that they were receiving the services they needed in the way that they needed. Next slide. In this graph, we can see the percentage of San Mateo County FSP participants that identify as Hispanic or Latino, Latina. By understanding this data, we have the opportunity to continue using the principles of data-driven decision-making. Aside from utilization trends, one of the things we hope to be able to look at is FSP outcomes by race and ethnicity. We are excited that the multi-county FSP INS project is supporting counties in building shared outcomes, developing continuous improvement processes, and shared best practices in equity. Next slide. Here, in these two graphs, the top one, we see utilization trends by race to ensure equitable services are being delivered in San Mateo County. In this slide, we are looking specifically at our adult and older adult FSP providers. The data generally mirrors our San Mateo County demographics, with the exception of those that identify as Asian, which would specifically focus on our Filipino and Chinese communities. The numbers you see here are not percentages, but are noted by participant count. And this is due to clients being able to select more than one race in our reporting. The inability to not be able to compare percentage is a challenge. However, we see that there is consistency from year to year in those that we are serving. The bottom part of this slide shows utilization by participants for our youth and TAY FSPs. And here again, we do not have participant, we don't have percent, we have the numbers by participant. And again, you can see consistency in those that are being served. Our FSPs, as will be shared by Kaminar in a short time, report program level race data to inform decisions around hiring of staff, language services, needs, and reach. San Mateo County Behavioral Health and Recovery Services continues to deepen its efforts to develop a culturally responsive and inclusive system in support of the behavioral health and recovery needs of San Mateo County's increasingly diverse population. We are always learning and appreciate this opportunity to learn together. I want to thank you all for your time, and now I'd like to introduce Julie Lang from Sacramento to share their exciting work.
Thank you, Maria. My name is Julie Liang, and I'm with Sacramento County. And I'm going to focus this part of the presentation on Sacramento County's full service partnership called Transcultural Wellness Center, or TWC, and our efforts in providing technical assistance and support to our providers that serve our diverse communities. So I don't know how many of you were around in 2005 when we first launched MHSA, but at that time for Sacramento County, we began our initial MHSA community planning process. We facilitated an intensive outreach to all of our local diverse stakeholders to engage them in community planning for the MHSA Community Services and Supports Component programming. We were able to engage our consumers representing all age ranges and their family members, our ethnic communities, our LGBTQ communities, and people living with disabilities. Many of these community members consistently attended planning meetings, and from that planning process, we received numerous recommendations for myriad community services and supports component programming from all stakeholder groups. It was during Sacramento County's public hearing for our initial community supports or community services and supports 3-year plan that there was robust turnout of Asian Pacific Islander or API communities who advocated for services that were culturally and linguistically responsive to their communities. So Sacramento County examined the data and identified opportunities to address the culturally appropriate services for members of our API communities by releasing a request for applications to operate a full service partnership called the Transcultural Wellness Center. And this Transcultural Wellness Center would provide culturally responsive and linguistically proficient FSP services to API individuals. So the provider that was awarded the TWC FSP contract was a smaller grassroots agency that for many years provided culturally responsive and linguistically proficient counseling services on a sliding fee scale to API community members. This provider, Asian Pacific Community Counseling, or APCC, was already implementing many community-based programs and services specific to the API community. So they really knew the API communities and were very adept at networking and outreaching to the API community members already. So given that APCC was a small grassroots agency, incorporating this FSP program contract more than doubled the size of their agency. Additionally, they were new to providing services through our mental health plan. So Sacramento County provided intensive technical support and consultation through the Medi-Cal certification process and during the first few years of FSP program implementation. We provided technical support and assistance related to key concepts and elements such as understanding Medi-Cal and mental health services and service codes, understanding both Medi-Cal and MHSA fund sources and billing, understanding the eligibility requirements of both fund sources, helping them understand policies and procedures that they should consider relating to and outside of those required for site certification, understanding the documentation process, internal utilization review tools and compliance standards, and really kind of helping them identify caseload sizes based on roles, such as your case manager, your personal services coordinator, your clinicians, your peers and family members, and then understanding productivity standards. So during the early years of implementation, we met with the executive director and clinical director regularly to review clinical concerns, service delivery concerns, and productivity and operational issues. One of the challenges that APCC faced was finding a clinical director from the API community who understood how to provide clinical and culturally responsive services within the mental health plan, as well as having knowledge of providing culturally and linguistically responsive services and peer and family member support services. So to implement the program, the provider really needed a clinical director that could lead the team of clinicians and personal service coordinators and peers and family members representing the API communities. It was the clinical director that was responsible and that is responsible to lead the team in engaging our API community members who needed FSP services, as well as leading the team to provide a full array of FSP services while also working with the county relating to compliance standards, using electronic health records, policies, and procedures relating to providing services within the mental health plan. We're happy to say that today this agency is Medi-Cal certified and has found a way to really balance services as well as balancing compliance standards or requirements. Next slide. So through the TWC FSP and other services, Sacramento County continues to explore ways to better serve, support, and improve outcomes for our diverse community members. So the bar graphs on this slide illustrate the number of API community members served through our mental health plan. Of the API clients served through our mental health plan, Transcultural Wellness Center serves over 87% of them. And then our other MHP outpatient programs serve just about 7%. The bar graph to the right demonstrates that over 58% of TWC's FSP clients have identified that a non-English language is their primary language, whereas 11% of the mental health plan outpatient program clients have identified that a non-English language is their primary language. So one of the ways that TWC FSP serves clients is through the utilization of traditional healing practices. They began supporting clients in this way from the very beginning of program implementation. They always wanted to emphasize wellness and holistic approaches rather than emphasizing mental illness. And so they have already established trusted relationships with the API communities and have assisted clients in accessing shamans, acupuncture, herbal medicine, and other traditional healing practices. Early on, they began offering Tai Chi classes and cooking classes for nutrition, but also as a way to build support for clients. So Sacramento County has provided and is providing technical assistance to support community-based organizations to provide culturally specific suicide prevention and awareness programs to cultural, racial, ethnic, gender, and sexual diverse communities. And we're exploring how to provide technical assistance and support to other grassroots providers that are focused on serving other racial and ethnic communities to provide specialty mental health services. Concurrently, we are exploring ways to encourage and promote partnerships with cultural, community-specific, community-based organizations that are successfully using community-defined evidence practices to achieve positive outcomes with our diverse community members, for whom many evidence-based practices may not have been evaluated. If you're interested in learning more about these efforts, please visit www.cultureishealth.org. Next slide. So this slide illustrates the wide range of API populations that TWC serves, with over half of the clients being monolingual. Many TWC FSP clients identify as Vietnamese, Hmong, and Chinese, but TWC also serves clients who identify as Cambodian, Mien, Laotian, and Filipino, and many others. Although many clients speak English, there are many whose primary language is Hmong, Vietnamese, Cantonese, Mien, and Mandarin. And later in the presentation, you will hear a visual or audio recording of a client that has been served by TWC, and you'll hear about their experience in receiving those services. So that's it for me, and I'm going to hand it off to Dr. Sharon.
Thank you very much. And it's really great to hear about what's happening in other counties. I want to just kind of take a step back to when I first arrived in LA about 4 years ago, and I do joke because it feels about 40. Anyway, you know, I became very familiar with the FSP program some time ago, and then when I got here and really explored the type of work that was being done and you know, populations that were being targeted, I felt like there was a really significant opportunity for us in LA County to kind of up our game. And because for me, the FSP programs in California are really the meat and potatoes, the foundation of community mental health. I did reach out to a number of different partners in the private sector and happened upon the Balmer Foundation, who's got a lot of interest in the way that government money is spent and making sure that it's accountable. And in dialogue with the Balmer Foundation and with Third Sector, we created this partnership where we had an outside entity, Third Sector, who kind of cut their teeth a while ago on performance-based contracting in the context of social impact bonds as someone that would help us. And really what we have tried to pursue, and we've been at it for a while and we're getting really close to kind of hitting the streets, is a model where we are incentivizing and supporting the type of relentless engagement and the array of services that are required to help those with the most significant needs get on the recovery pathway. The counties are different. And I'm not going to say that LA County has things that other counties don't, because I think the majority of counties have a massive problem with, homelessness and with incarceration of people that have serious, profound mental illness. But here it's a massive, massive challenge. We're probably right now at about 100,000 people who are homeless, although we didn't do the PIT count because of COVID. And I'm going to say that about 10% of that population is really suffering from disabling mental health challenges. And we, as a department, need to step up, not just with capacity, but also the quality and the intensity of services that are required. And one of the things that immediately kind of struck me about the FSP programs was this concept of slots, where our directly operated clinics and providers were funded, staffed to deliver FSP type services for a number of slots. And the issue with the slot model, from my perspective, is that you have to fill the slot and provide the services, as opposed to saying we're going to fund a team, and that team is going to have responsibility for a population, and that population will be followed relentlessly, no matter where they go, all the time, to make sure that they're always kept into the community, brought back into the community, given an array of services, which is not just treatment, but also addressing the social determinants of health, which are critical for anyone to get back on get onto a recovery pathway. So when an individual is receiving, is being served by an FSP team, when they go into the hospital, or they go into the street, or they go into the jail, that's a trigger for the team to engage. It's not they're too sick, so they have to go into the hospital, we're going to wait. It means engaging with the team and that person in the hospital. When they go to the streets, we can't find them. We have to find them. And if they're in jail, God forbid, engage with the jail and get the person out, and figure out ways in a relentless fashion, heart forward, to keep them in the community. One of the things that's critical here is making sure that the people that are doing the work are adequately trained, and that we've got enough staff, and that case ratios are not unmanageable. And what we've done there is really tried to figure out a funding strategy that is adequate, and to create a relationship that's really customer service oriented, where the department has got an ongoing dashboard with providers and with our own staff, so that we know what's going on, and that we can always provide support in real time to optimize the chance of success for any given case, and for a team who is responsible and accountable to a population, and beyond that, to incentivize success. So if individuals are not going into the hospitals, or into the streets, or into the jail, that takes a lot of work. And we need to recognize that, and we need to resource that. And for me, at the end of the day, when a client who meets criteria for FSP, and it's probably different in different communities, and I could only say I wish I had 5 times the amount of resources in LA County, at least, for that many more teams and that large of a population, so that we could serve, that we could expand out the people that we could deliver FSP services to, because the needs are so massive. But we can't. And if we ultimately incentivize an FSP team having an individual who is a part of the population they're responsible to, and handing them off to our community system of care, our outpatient clinics, that's a big deal. It means that someone's come in with a tremendous amount of needs. Those needs have been addressed, and the team is comfortable handing them to a lower level of care. And when that happens, that needs to be recognized. So we're incentivizing that in order for us to target the populations that are in the most needs. And very germane to our conversation today, in an equitable way, we have to collect data. We have to be able to track, to collect, analyze, and track data about where our investment goes. Is it going to the populations that we need to target because of their needs? And is it going to populations who have not gotten their fair share for many, many, many years due to institutional inequity, structural racism, other things? But it's only if we collect that data, and it's only if we analyze it and we use it as in an ongoing improvement manner, that we're ever going to get our system and hopefully the state to kind of get the outcomes that were really imagined when Prop 63 came through. I do want to recognize the OAC, who early on became very interested in the work that we were doing. And in conversations with Toby Ewing specifically, he just was saying, I love what you guys are doing. Can we figure out a way to invest in other counties to bring on additional efforts, leverage stuff that had been done, do things that are tailored to other counties, in collaboration with third sector. The last thing I'll say is that none of this can happen, and really nothing can happen in the health and human service industry in particular, if everybody's not engaged. These are collective problems. They require collective solutions and collective input. And I'm not going to say we've done a perfect job, but I can tell you we've tried really, really, really hard to engage with the community. And I mean that in terms of individuals who have received or will receive services. I mean that in terms of family members. Obviously, the multiple amazing network of community-based organizations that we contract with, our staff, and that we develop not only a programmatic approach, but a business model that is feasible, that is sustainable longer term. And I do believe that as we move forward and we figure out how to coordinate our systems more effectively, to prioritize, and also to make really, really clear to the state of California, to the Department of Healthcare Services and Health and Human Services and the governor, as well as to our federal government, that we do not have the capacity to deliver what we're being asked to provide. But if we do things like this, where we know money is being spent effectively and outcomes are being collected and articulated and marketed, we can then make a much, much stronger argument that behavioral health is underfunded, needs to be prioritized, and with more fuel, we're going to do what everybody wants to do. And that is to push the recovery movement, because none of us are well until all of us are well. Thank you very much.
Thank you so much, Dr. Sharon, and we're really grateful for your partnership in this effort and for helping push the whole state forward, and LA County sharing its amazing work with the other counties so that other counties can really build off of it. Zach, if you don't mind going back one slide, just wanted to tie some of these threads together from across the counties. We heard from San Mateo, Sacramento, and LA County about how they've innovated locally on responding to equity needs, on responding to community needs, and really listening to the community about what's needed in an FSP. We think one of the most important things to do as a next step is to build some of that consistent data, collect consistent data, define shared outcomes and collected outcomes, and then start to work collaboratively, both locally with providers and then across the state, to examine that data and continue to improve on outcomes, as well as understand where those communities are being underserved and work to reduce disparities that way. We're really excited that LA County has taken that approach and built a sustainable continuous improvement system, as Dr. Sharon just described, collaborating with UCLA and providers going forward to examine data and understand disparities. and that method and vision is being translated statewide through this multi-county FSP innovation project. And we think the result of these two projects will be that all the innovations you heard about today from counties in responding to local needs can then start to be talked about in a peer forum and shared statewide, so that we get to leverage all this hard work outside of just a one county process and really move to a collective way of working together on those really important outcomes, and over time reducing disparities in outcomes. So that's just a little bit about why we're all here today and the vision we have as a collective. I'd love to turn it over now to Christopher Dirks from San Mateo County's Kaminar FSP program to share their perspective.
All right, thank you very much. My name is Christopher Dirks. I'm the FSP and AOT program director at Kaminar. Next slide, please. Diversity, equity, and inclusion, and cultural humility have been actively prioritized at Kaminar for more than 10 years, and certainly at the encouraging of BHRS. It starts with determining our consumers' identity and needs, including linguistic needs, to determine how to best support consumers in achieving their goals. Special thanks to BHRS for creating a special collaboration with the local police departments so that we can actually more effectively find and serve clients that have mental health needs instead of them going through the criminal justice system as much as possible. Next slide. We begin with having our staff ask how the consumer identifies themselves and what's important to them to understand in order to understand the client as an individual. Even within communities, there are differences, and we want to understand each individual client. For example, I was working with a father and son and asked them how they identified. Just from appearances, I might have assumed that they would identify as Black. However, they responded that they identified as Moorish, which if I had not asked, I would not have led to the understanding that how they understand themselves, nor for an appreciation for their values and their importance. This led to goals that were meaningful to them and strengthened our working alliance. Next slide, please. Hold on just a second. I want to make sure I make it right. For some clients, community, churches, and or extended family are important parts of their life. Incorporating these as natural supports in the community acknowledges and honors their inherent supports that will help them succeed in a meaningful way to them. Our local Pride Centers play a large role, support, and resource for supporting our LGBTQ consumers, and we are blessed to have these rich supports. We have had our DEI community for over 10 years with meetings on a monthly basis. In weekly staff meetings, we often discuss staff culture, race, acculturation, and diversity, as well as follow up with conversations with clients about experiences with these. We also problem solve difficulties with having these conversations in the first place. Our wellness support specialists are essential in linking our consumers and staff, as well as supporting our consumers in involvement in their progress. Our wellness support specialists strongly advocate for our consumers and help us improve our services. Upon request, consumers can ask for gender, ethnic, religious, specific staff for their service partner to pair with their identity. Consumers have any preferences for services and service providers. Next slide, please. Feedback and feedback informed treatment is currently implemented in all of our case management teams, giving the consumers a weekly prompted opportunity to give us feedback on how well we are serving them and how they're doing in reaching their goals. Staff have occasionally received low scores, addressed them with the consumer in an open conversation about what was missing from the session and change their support to realize an improvement of services during the following week. On our hallways, we also have pictures of our consumers that represents the diversity of the population that we work with. Next slide. So as we can see, we have Kaminar in terms of staffing, and the general demographics of the county are reasonably well matched, as you can see. Next slide. And here we have a representation of the clientele that we serve. And just to point out that we do have a few consumers that are deaf, and we use appropriate sign language interpretation with them. Next slide, please. Yeah. Okay. Thank you very much.
Thanks so much, Chris. Really appreciate hearing from you about all the work that Kaminar is doing. It's really amazing. Next, we wanted to share a pre-recorded video of an interview with an FSP client from the Asian Pacific Community Counseling Transcultural Wellness Center program. This APCC TWC program is the program that Julie Leung from Sacramento was talking about earlier. We're really excited that this FSP client was able to share his perspective. And I did want to note that the interview was conducted in Hmong, and we provided translations. So just for ease of listening, you'll be hearing the questions asked in English, but they were asked to him in Hmong. And this consumer is receiving culturally and linguistically responsive services that he shares a little bit more about in the video. So Zach, yeah, please go ahead and play it. Thank you.
What kind of psychiatric treatment have you received from APCC WC? You mentioned you were a shaman. What does shaman have to do with your experience and your mental health? What does your family think about mental health? Are they supportive of your mental health? How does the Hmong culture perceive mental health, illness, and healthcare? What barriers does the Hmong community face in assessing mental health services? What would you like to see a change in the Hmong community with mental health? How can the social and health system within Sacramento County be more responsive to the mental health needs of the Hmong community?
Great. Thank you so much, Sacramento, for sharing that video and highlighting the important work the APCC and the client's experience. So that actually concludes the presentation portion of this session. And so I'm going to move us on to the response panel. And for the next about 60 minutes, we'll be hearing from an incredible panel of individuals from across the state. For the first 30 minutes, I'll ask a series of pre-collected questions. And then for the last 30 minutes, we'll be opening it up for Q&A. So as Arel mentioned earlier, there should be a small Q&A button at the bottom of your screen. Feel free to type in your question into that section at any time over the next 60 minutes. We've already received a number of great questions, so thank you all for those who have already submitted. Once we're done with our pre-collected questions, I'll move over into the audience questions and we will get through as many as we can. So my name is Nicole Christie and I'm a director with Third Sector in the San Francisco office, and I will be moderating our panel today. So I will give a few minutes for our panelists to do a quick round of introductions before we get started. So Doris, do you mind kicking us off?
Sure. Good morning, everyone. I'm Doris Estremera. I'm the Mental Health Services Act Manager with San Mateo County. My position is actually uniquely placed under the Office of Diversity and Equity. So I get to work really closely with Dr. Maria, but it's in our team in thinking through really equity and inclusiveness across all our programming.
Great, thanks. Mary, you want to go next?
Sure. Good morning, everyone. Mary Nakamura. My pronouns are she, her, and hers. And I'm the Cultural Competence and Ethnic Services Manager and Workforce Education Training Health Program Manager for Sacramento County Behavioral Health Services.
Thank you. Lisa?
Hi, I'm Lisa Wong, and I'm the Senior Deputy Director for the Department of Mental Health. I'm a psychologist by training, and I am over the outpatient and community services for our department.
Thank you. And you all just heard from Christopher, but Christopher, if you'd like to say anything else before we jump into the panel section, please feel free.
This is a wonderful population to work with. It's very challenging and rewarding at the same time. I'm looking forward to hearing from our consumers.
Great, thank you. We also have a FSP consumer from San Mateo County. Stafford is on the line. Stafford, if you'd like to say anything, please feel free at this time.
Yeah, my name is Stafford Elahi. I'm a FSP client of San Mateo County. And I'm happy to be here.
Then we are very happy to have you. Thank you for joining us today. And finally, we have Dr. Dante Early.
Hi, my name is Dr. Dante Early. My pronouns are she, her, hers. I am the Chief of Research and Evaluation for the Mental Health Services Oversight and Accountability Commission. Thank you for having me.
Great. Thank you all so much for joining our panel today. I am going to start us off with a couple of questions for Dr. Dante Early. So Dante, starting with the thought around translating evidence-based practices, how can we support FSPs in incorporating the lessons learned and community-defined evidence from the California Reducing Disparities Project Phase 2 to improve outcomes and reduce disparities?
That's not a large question at all. Okay, so
we go big here.
So I think the first step in doing that is even in the context of the question, right? Which is, how do we somehow get community-based evidence programs and the results that we're getting from these programs to the level, right, of what we would normally use, right? And so I think even in the context of the question, you automatically are creating this hierarchy, right? And prioritizing community-based evidence programs with what we would say would be normally traditional. And so I think the first step is actually a mind change and a shift in the way that we prioritize and the way that we think about community-defined evidence programs, right? They are at the same level and have the same importance as what we have had and seen in the past. They just have not been given the same in our minds, right? Or even with our funding streams, the same importance. So I think that's the first step. I think in thinking about not only the information and what we just heard in the presentation, but also what we're seeing in regards to actual data at the state level and what's being reported. I think being able to connect individuals to programs so that we can better understand FSPs is also a key. And so right now, the data that we get and that you will see, for instance, on the transparency suite that we have at the commission is we talk about FSPs, we talk about demographics within FSPs, but right now we are unable to connect individuals to the nuances within FSPs, right? It's FSP as a program, but we know that within an FSP, there are so many things that you're doing, right, that are tailored to whatever it takes for your program. Right now, the data doesn't support being able to understand what those differences are. And so I think the other step in this is being able to actually have data so that you can see what's working for certain communities and what's not working for other communities, right? Our data doesn't currently support that. And then if I just in thinking about this, I think one of the other things is what we are prioritizing as outcomes. And so although we collect data on reducing criminal justice involvement, right? So we ask about where your homelessness, we ask about foster and attendance and these other outcomes. We don't ask about things like ethnicity and cultural pride or pride in your ethnicity, right? Which we know are connected to our self-worth and our mental health. And so when we think about how do we begin to incorporate and really place just as high as value on what we have previously collected, I think really trying to incorporate those outcomes that we're seeing and those kinds of questions into the data we collect would be important. I think I completely went over 3 minutes, Nicole.
No, all very interesting. Please take the time that you need to appropriately answer the question. We have a good chunk here for lots of different questions, so no worries. I do have another question for you though.
So then the last thing I would add to that, if you really mean that.
I do, I sincerely do.
Is intentionality. And so when we're thinking about equity work, when we're thinking about really starting to address disparities, I think we also have to challenge ourselves that it is not simply on the grantees or the program providers within the California Reducing Disparities Project to come to the counties, right, and say, hey, this is what I'm finding. Can you please fund me? Can you please fund me? Can you please fund me, right? But also being intentional at looking at your programs, looking at what at a county you're currently doing, and saying, hey, I know there are areas that we can strengthen. Let me go out. Let me start to do some of that work to engage the communities, to engage people that are already working here and leverage that and start there versus we don't need to start from scratch, right? And so I would say intentionality as well.
Great. Well, kind of moving that thought a little bit further, thinking about kind of the statewide context, what advice do you have for counties who are seeking to balance local context and respond to stakeholder needs, therefore driving service equity, while also ensuring the ability to compare and interpret data statewide?
Okay, so I think for me, one of the things in thinking about this question is understanding the data that we are collecting both at a county level and statewide. I immediately thought of SOGI data and the fact that we are now required to collect it, which I think is a good thing, because how do we understand whether we are moving the needle if we don't even have a measurement of the communities, right, that we're trying to support? But what we are seeing, for example, as we're looking at the SOGI data that we're getting, is that it's not populated. It's almost all missing, right? And so I think one of the things that we at the Commission are trying to do is better understand and actually use the data that has been required to be collected for so long. And so having this understanding of, here's the data landscape, right? And really starting to be able to not only use it, look at the quality, look at what's missing, but more importantly, then communicate back to the communities, to the counties, this is what we're seeing. I'm a strong proponent of do not collect data that you're not going to use, right? If you are collecting data, especially as a mental health provider, that means you're taking time away from providing services to document, to write out. And so if you are going to collect that data, it's so important that you see, one, it's being used, and two, it's being communicated back to you so that you can begin to implement, to really learn. Obviously, at a county level, you have your own data, but you don't know what other counties are doing, and you don't know what the landscape looks like from other counties. So at a statewide level, I think of it as our responsibility to put all that data together, so then you can begin to say, what's going on in that county? That looks like they're really meeting the needs here. Or how are they getting so many community members from that community that we know we want to target as well to come to the table? And so first, being able to collect that data, to really assess it, that there's this loop that's coming back. And then for me, more importantly, that we're then coming and saying, okay, so are we asking the right questions of the data? Are we communicating the data in a way that is useful to you so that you can really truly understand and then use it? And then the other thing that we've started trying to do at the Commission, and I'm sure you've seen it, is then begin to link to state data sets that at a county level you don't have access to, right? So how can we do better to support counties in really understanding what's working and not working? And I'll give you a couple of examples. We took all of the FSP and CSI data that we get from 2006 and forward, and we link that to Department of Justice data to really begin to understand at an individual level, right, at a client level, to really begin to understand as FSPs, as we are implementing these programs, are we actually seeing a reduction in criminal justice involvement? Are we seeing reductions in arrests? Are we seeing reductions in convictions? Are we seeing reductions in the types of crimes, right, that individuals are being prosecuted for? Are we seeing reductions in IST, right? All of that data we are trying to better understand and then communicate back, this is working or this isn't working. But remember, again, we don't have connections individual to program. And so we can say at a high level, FSPs are having this impact, but not what kinds of FSPs are having an impact on the communities, again, that we're trying to differentially target. The next thing, we just got data from EDD, again, to do the same kinds of things, because what we saw in criminal justice involvement data and making that linkage, we saw a 65% reduction in criminal justice involvement for FSP clients that had had 3 or more arrests prior to enrolling in an FSP. That meant, again, FSPs are doing their intended job, right? We should be investing more in FSPs, again, to ensure that if we are investing in the community and the community supports, that individuals are not having contact with the criminal justice system, right? Which is what we want. We are now collecting that data and connecting that data to employment development. So quarterly wage data. Are indeed FSPs connecting to reducing unemployment, right? Is it supporting long-term employment? Is it supporting a prevailing wage, right? Livable wage. So we are now being able to make that connection. We also recently executed a data use agreement with the California Department of Education to be able to do the same thing at an individual level over the course of decades. Are we seeing that these programs, FSPs, and also at the CSI level, so getting services, are we seeing a reduction in what we would call school failure, like suspensions, expulsions, attendance? But even more importantly, we are now connecting all of these systems at a state level, at a data level, criminal justice involvement, schools, employment. We are also getting death and birth records. A system that begins to look at a whole person. Is, again, FSP reducing school failure, which then is reducing the likelihood that you go into the criminal justice system, which is also increasing the likelihood that you have employment. And so at a state level, I think that it's our job to connect those systems and then work with counties to get the rich data sets that are available at the county level so that we can better understand the individual programs that are supporting these outcomes.
Thank you so much, Dr. Early. We're so grateful to have that MHS OAC perspective today. You've certainly given me a lot of food for thought so far, and I am very excited personally to see how you're able to continue to push forward a lot of that data innovation. So thank you again. I'm gonna move us along here. We do have a question for Sacramento County. So thinking about county-wide initiatives, I'm wondering, Sacramento, Mary and team, you shared some FSP specific initiatives in this presentation. How is the innovation project supporting other county-wide initiatives, knowing that FSP is part of a broader mental health ecosystem?
Hi, thank you. Great question, Nicole. And again, my name is Mary Nakamura. My pronouns are she, her, and hers. Cultural Competence Ethnic Service Manager with Sacramento County Behavioral Health Services. And I just wanted to thank Third Sector and all the presenters and panelists for sharing and for all the attendees. I'm looking forward to great discussions later on. I also wanted to just acknowledge a land acknowledgement in Sacramento County, that the land in Sacramento is the tribal land of the Nisenan people. And Sacramento was a gathering place for many local tribes who've lived throughout the Central Valley and the foothills for generations and were the original stewards of this land. Also want to acknowledge the Southern Maidu people to the north, the Valley and Plains Miwok and Miwok peoples to the south of the American River, and also like to honor the Patwin Wintun peoples to the west of the Sacramento River. And just acknowledge we're standing on tribal lands of Sacramento's indigenous people. So in terms of the how the innovation can kind of spread across countywide initiatives, I wanted to just say that in Sacramento, we're part of, and so is Dr. Maria Laurenti, we're ethnic service managers, and we're part of a larger statewide organization of the County Behavioral Health Directors Association, has a group for the ethnic service managers of all of the counties and cities in Sacramento, or excuse me, in California. And we make up the Cultural Competency, Equity, and Social Justice Committee. And in terms of the efforts collectively as a state, all of the counties, have a real desire for collecting, disaggregating, and discussing data to better translate and share best practices for driving equitable outcomes. And so I just wanted to put that out there, that that is a focus for all of the counties. It might look different in terms of who lives in our counties and the populations that we serve, but just wanted to point that out. In terms of, and I want to thank Julie for sharing the history of the Transcultural Wellness Center, but I also wanted to talk about, we realize that, there's such wisdom in the communities, and there's several community-based organizations that are in our county who really know how to help support their community members. And we've been able to have prevention contracts with, as Julie mentioned, with 9 of them to provide 10 different suicide prevention and awareness programs, and also programs that help address timely access for underserved communities. And many of these organizations, they're very, very small. We're talking maybe like 1 or 2 or maybe 3 people in the organization, to a little bit larger ones. But they all share something in common in that they have the knowledge and the trust of the community. And so we want to make sure that we're providing technical assistance and support to these organizations. We've, through our Supporting Community Connections program, which again is a prevention and early intervention funded program. So it's not a full service partnership, but it's, we've worked with the providers to help inform, what does data collection look like for us? How would we ask this question? What's important to the community? How would your community say this? Because we found that not all communities responded to how to ask about suicide. And so we had to really, shape and tailor the questions for each community. And in Sacramento County, we have just diverse, just like San Mateo and LA County, but we have 7 threshold languages, and there's even more diversity beyond just those communities speaking those languages. But so we need to make sure that we are, being intentional about getting to know the communities, building those relationships with community partners. And one thing I wanted to highlight in terms of learning for us, we've just like all counties have focused on cultural competence and cultural humility, and provided required trainings for the state cultural competence plan requirements. But this year we are focusing in our county on a slightly different approach. So we're focusing on racial equity and behavioral health equity. And this is for our whole behavioral health system. And our behavioral health includes both mental health and substance use prevention and treatment. And we are partway into a year-long pilot called the Behavioral Health Racial Equity Collaborative. We are working with California Institute for Behavioral Health Solutions, CIBHS. They are doing the primary facilitation with us and have hired a community facilitator as well. And we're focusing because, we want behavioral health equity for all. And we realized that we needed to take a targeted universalism approach. And so, meaning that we have to look at, for each community where there's disparities, what are the structures in place that are preventing positive outcomes for community members, and what can we do? And so we are piloting this year with the African American, Black, of African descent communities in our county. And we've developed or formed a steering committee for the Behavioral Health Racial Equity Collaborative, made up of half of community members and then half of our BHS leadership. And the steering committee has been involved. They've created a vision and value statement for the collaborative. They have looked at various data sources. So we held community focus groups to get input from the community on how behavioral health services can be improved. And we also did an internal look in our behavioral health staff on how perceptions of staff in terms of where we are with addressing racial equity. The management has, for the county in behavioral health and also in our child welfare, we've taken implicit bias training by Dr. Marks and had a two-part, and we're looking to see how we can incorporate that training to more of our behavioral health service system. And so the steering committee has identified 12 goals that they would like the county behavioral health services. And then we put the call out to our provider system to see who would like to join the county in, we're taking a deeper dive, working with community and developing racial equity action plans. So there's 8 providers in our system that volunteered to join us in this endeavor. And we're going to be starting our first learning session, and with the goal of really hearing from community, hearing from our communities that we serve, especially the African American, Black, of African descent communities, and really make some significant changes. I mean, we look at data, but this whole process, I think, is going to be a real tangible way for us to identify benchmarks, and also accountability to the community is really important. So being able to hear from the community on what changes they wanted to see, doing what we need to do to put those changes into effect, and then communicating back. So that's an exciting process that we're doing. And then just wanted to touch about the workforce education and training part of it too. And because hiring and making sure we have staff that throughout the whole organization that are reflective of the community being served, that's so important for us. And we are going to be taking a look at that with our initiatives with the statewide workforce education and training programs through the regional partnerships. And just to Dr. point about seeking out counties, encouraging counties to seek out the wisdom of the community defined evidence practices. Thank you for that. And just wanted to remind folks that we put the cultureshealth.org website on the slide. So if your county would like to look at who all is involved with who are the 35 different programs that are currently in this funded in this program, and to reach out to them and to learn, what they're doing and how what they're doing can be incorporated into what you're doing, please go check out their website. Thank you.
Thank you, Mary, for that very thoughtful and thorough answer, and also for the land acknowledgement. Next, I would love to hear from Stafford, if that's okay with you. My question for you, Stafford, is what, in your opinion, as someone receiving services in San Mateo, are some of the most important elements of equitable responsive services? So how do we know if a program is meeting consumer needs and goals?
I would say usually by the case manager. If the case management is getting good feedback from the client and the client is responding well, that's a good way of finding out if things are going well or not. What was your next question?
Yeah, my other question was, what are some of the things that you think are really important elements of equitable or responsive services? So what are some of the things that work well for you?
Usually, like I said, it's pretty much up to the case manager. As far as I've gotten with the FSP, the case manager, the peer counseling, schooling. Schooling was very helpful for me. It helped me deal with my peers better on a different, on another level. And let's see. Yeah.
No, that's great. Thank you for sharing about. Oh, go ahead. Please continue.
That's pretty much it. The schooling and the FSP reaching out to provide special education, supportive education.
Great. Yeah, that's great to hear about the case management and the peer counseling schooling. Is there anything else that you would like to share with the group around your FSP experience?
I would like to give a special thanks out to Christopher Robinson. He's from special education, and Janae Grant. She's from supported education, and as well as Christopher Dirks. He's been very instrumental in helping me process things and put things in a good perspective. I've been in a situation where I was falsely arrested for a burglary, and it was a situation where when I was incarcerated, I lost my voucher, my housing voucher, and it's I believe it was an issue of a Black Lives Matter issue that I didn't press fully like I should have, but I did talk to Keminar about it, the FSP branch, and they did support me by helping me with they subsidized my housing so I would have a place to stay. And it was perfect timing, and it was very helpful for Keminar to do that with me, to subsidize my housing. And I think they've always been respectful of me. I haven't had any racial run-ins or anything like that, because mainly from the 11th grade, I've always had the perspective that I've always had this perspective that hold on.
Sure.
Okay, I've always had the perspective that all men are created equal, and we are created by our creator with certain rights that can't be taken away from you. So I've always had that as my as backing to me, you know, because of you know, things that African Americans go through or they endure, you know. So I've always had that as a backing to me that I have rights that can't be taken away or can't be alienated. And I just wanted to say that you know, I really appreciate Kaminar for helping me subsidize my housing, and I would I'm pressing on them to help me a little further by getting my voucher back. They've my case management, Anna Dukovic, she's been very helpful in helping me try to find housing where I could live on my own and without a roommate. And it's everything is going pretty good.
I'm so glad to hear that things are going well right now. And thank you so much, Stafford, for sharing your personal experience with us. We really, really appreciate it. And we're so glad to have you on this call today. So thank you again.
Okay, thank you.
I want to build off a little bit of what Stafford just said and keep on with San Mateo. Stafford, please feel free to jump in if you would also like to answer this. But for San Mateo County, how can community engagement be further leveraged to understand and reduce disparities?
Go ahead go ahead. I'll speak after.
When I said earlier that I was falsely accused of a burglary, I figured that that FSP and the law enforcement could benefit by a RAP plan, by everybody having a RAP plan that you know shows what you're going through and what you're facing, and a RAP plan will be very instrumental, and also a smart van or a smart team to diagnose you right on the spot to see if you're having any difficulties or any mental health triggers that's offsetting you away from a crime that some people will probably think that you may be doing or whatever. So that's the bulk of what I wanted to say.
Thank you so much for that personal perspective. Doris, I think you had something you wanted to add.
Thank you, Nicole. And yes, thank you, Stafford, so much for sharing your experience. I think that's really does emphasize how important it is to have our consumer voice in the community engagement in our planning, our data analysis. And so what I wanted to share was one example of how we've done that community participation in data analysis in San Mateo County. So Maria, you heard from Maria, Dr. Lorente, describe the San Mateo County Health Equity Initiatives. And as a reminder, these are collaboratives. These are collaboratives of consumers, family members, peers, our partner agencies and BHRS staff. And one of the things that, so we have 8 in San Mateo County, and they're representing various diverse cultural groups. And I think in lieu of some of the utilization data that Maria shared, my example is gonna be focused on our Chinese Health Initiative. Our Chinese Health Initiative undertook this task of reviewing access to mental health services data for the Chinese community in our county. So they reviewed everything, and they took this project on, as an amazing effort to review demographic data, prevalence, penetration rates, and from various sources, looking at DHCS, our BHRS quality improvement, even our public health policy and partners who at the time had done a huge language access study and regularly do community needs assessments. This data was also supplemented by focus groups so that we can really hear again from our clients or community members, conducted in Chinese, feedback from workforce development efforts, also led by CHI, the Chinese Health Initiative, and outreach events. This data that they looked at literally covered about 5 years. And I'll share a few things, what was learned in that process. And this was, we learned, that, at the time we had a BHRS Chinese speaking clinician who was hired to serve the community. This Chinese speaking community is one of our threshold languages in San Mateo County. This clinician had only seen 10 Chinese speaking clients in the span of 5 years. Yet, as I mentioned, this is one of our threshold languages. Since then, this was, at this point, it's 10 years back, where we are now. This whole study and some solutions came out of that. Since then, we now track preferred language in our EHRs. So for every client, we're able to offer those comprehensive language services and including clinician and client matching. So now when I look at our data, our Chinese languages and dialects represented 80 clients this past fiscal year, compared to 10 in 5 years that I had shared 10 years ago. While there still may be a low utilization rate when you think about the Chinese population, I think it's hopeful to see that, a lot of these efforts do increase access, and a lot of the solutions, really did come from the community. One of the things that we learned also from the language access study was that our Chinese speaking community, because of the lack of language access, we're seeking care in San Francisco, it's our neighboring county, or relying on home or direct store remedies and or delaying treatment. The focus group data highlighted that Chinese speaking community had very little knowledge about the available mental health services in our county, and it really led to a deeper understanding of the challenges related to stigma. And so this whole comprehensive really look at the data and taken on by our Chinese Health Initiative led to a development of a white paper with proposals. We were able to fund one of those ideas, and it was to bring a Chinese speaking navigator under the Office of Diversity and Equity so that we can really focus the work. In 1 year, this Chinese Health Initiative was able to link 42 Chinese community members to behavioral health services. The Chinese speaking navigator also established key partnerships with a local community health center that targets the Chinese community in our north part of the county. And this health center actually gained a better understanding of the types of services that we offer at BHRS and began to refer more clients. And so it's part of one of our regular referring agencies. It also became clear that there was a need for mild to moderate. So that health center opened up their own mental health service program within the clinic. And our navigator was eventually hired by them to provide their patient outreach and engagement. So I think this, again, it's just one example of how community-led data analysis really leads to responsive services. Stafford just shared, his thoughts around having RAP plans, and that comes from personal experience. I think I really, really value that. And we've seen that in both, actually in a few of our initiatives now as well, our Pride Initiative and the Filipino Mental Health Initiative and our Pacific Islander Initiative, who have all proposed projects for MHSA innovation, successful projects. We're in the final 5th year of our Pride Center, which was a coordinated service approach for the LGBTQ community. And we'll be launching this next fiscal year a social enterprise that's really modeled, social enterprise model for the Filipino community, primarily youth, that's focused on cultural identity and the value of promoting cultural identity to support mental wellness. So our Pacific Islanders also going to be doing an innovative program with our youth. So again, just highlighting, how some of this and all of them involved a pretty exhaustive needs assessment that the collaboratives led. So in terms of, I think also just in leveraging more of this community engagement, I think one of the things I've been thinking a lot is because we've been mostly describing kind of a broader scope across utilization, right, of our services, which is important, but I think also at the program level is where I'd like, San Mateo County to go next. I really appreciated hearing, the efforts from Dr. Early that are happening statewide. I think, those sorts of things we want to learn from. And I think that's also what this FSP project's about, to help us think through at a program level, how can we take Staffords and other, clients, in a regular ongoing analysis of data so that it becomes a qualitative kind of improvement process, right? And I know that's one of the goals of this project. So I'm really looking forward to building off of that and kind of honing in at the program level. Mm-hmm.
Thank you, Doris, and thank you, Stafford. Appreciate those answers. I want to shift now just a little bit and pose a question to LA County. So LA County's a unique geography, but counties across the state share many challenges and opportunities, especially as it relates to improving equity and outcomes in FSP services. So I'd love to hear from you, Lisa, what resonated most with LA County DMH from the other counties' presentations and thoughtful answers thus far today, and what shared challenges and opportunities do we all have as a collective of counties?
Thank you, Nicole. I think there were so many things that everybody mentioned that really resonated with me. I know that a lot of times when people look at LA County, sometimes they call us the other state, but really, I mean, at the end of the day, we are sort of a collective of smaller communities. And I think that what is impactful and meaningful in other settings also applies to us. For instance, because LA County is so large, we have over 10 million people, we've split up into 8 what we call service areas. And each service area has a very particular demographic typically, like in terms of ethnic and racial makeup, socioeconomic status, different determinants of health factors. And I think for us to be able to really address equity issues and disparities, we have to look at that local, more micro level. And that for LA has always been the challenge. How do we take a broad perspective at a macro level, but also, look with intention at a local level to be able to address what's really going on in our communities? So I think that what everybody has shared has really resonated. I think in particular, I wrote some things down, what Julie had shared about Sacramento, in their usage of alternative healing practices. I think that is something so important and something that we would like to do more of in LA County, and we see as a challenge. There are so many times, I started off working in Skid Row, in the Skid Row area of Los Angeles, and we had all kinds of people come into our clinic, and some folks would come in and ask straight out for services, and other people I would see come in and say, they need to see a doctor because they don't feel well, or if they're from the Spanish-speaking population, they'll say, nervios. And then they would be turned away because they don't sound like our SPMI population, you know, but you have to take the time to figure out, okay, what's really going on and what might be a way to engage a person. So one of the things we started was a substance use disorder group for people with co-occurring disorders that also collaborated with the curandero. And in that way, it was something that felt familiar and acceptable to a population, but also let us work with them in terms of the dual diagnosis issues. And we've had some success with alternative healing practices in the API population too, like being able to pair acupuncture, acupressure, along with our more traditional outpatient services. But I think instead of having all these like little pilots of things that we want to do, we have to look across our broad system and ask ourselves, how do we connect with people in a meaningful way? And what practices from their culture could be a bridge or could be a part of the recovery journey? We have to, I think, really work in partnership for that. So I think that was really, something that resonated, but also something Chris had shared about just asking people how they identify. I know it seems like something so simple, but sometimes one of the things we struggle with in LA is just the volume. Like one of the clinics that I used to work in, we would have about 225 people come in a day. And, people had caseloads of like 150 to 200 easily. And when you're working with that volume of people, and you have a 13-page adult initial assessment, it's really easy to just like plow through all the things that are necessary. And you forget to take the time to, start from the client's perspective and to ask them something as simple as, how do you identify in terms of like race or ethnicity? And, like Chris had brought up, the client he worked with was identified actually as being Moorish instead of being African-American, which might have been an assumption. And I think it's so important for us to start with that, but also sharing the diversity of a program. This is another thing that Chris had mentioned about having pictures of people on the wall so that people get the feeling that we are about representing all the people that we work with, that we're not just, one color, one race, one religion, whatever, but that there is diversity throughout our programs as well as diversity throughout our staff.
Thank you, Lisa, for tying so many of those threads together over this conversation. Okay, I'm gonna open it up. I know we don't have too much time left, but I wanna open it up to a couple of questions for the whole panel. One of my first questions is from the audience is, how much is the faith community integral to this FSP transformation programming and services?
Oh, hi, I'll take that. Thank you for the question. And the faith community is very important to the FSP transformation programming and services. It's really about looking at what recovery means for an individual, and for many individuals, faith and spirituality is such a huge part of their recovery. So I know that as Julie had shared about TWC, Transcultural Wellness Center, the faith community played a big role, and also plays a big role in terms of working with our diverse cultural, racial, and ethnic communities for whom their faith and spirituality is very critical, and those are kind of the trusted kind of messengers in that community.
I would just add to that, in San Mateo County, one of our health equity initiatives or collaboratives that Doris mentioned is our spirituality initiative. And, I know at one of our clinics in the past, the spirituality initiative created and hosted a group, I believe it was 8 weeks long, on spiritual values. And I know one of our FSP clients who attended, and just how rewarding that was to her to be part of that. And there's a lot of examples of the I think, impact of our spirituality on our wellness. And that is, for us, one of the, I think, big drivers is our spirituality initiative and their creativity in getting our partners involved, our clients involved, our families. I mean, it just is throughout the county. So I really appreciate this question.
Thank you both. Okay, I'll keep moving us through the questions that we have received from you all. So let's see here. Can you further, I think this one is directed towards LA County again. So can you further connect what Dr. Sheeran said about emphasizing or prioritizing certain FSP populations and how that connects to reducing disparities?
Sure. I think this has to do with what Dr. Early talked about, you know, kind of setting forth with intention in terms of addressing disparities. Because a lot of times, you know, we collect data and we don't really use the data enough, I think, to shape what it is we do and how we move forward. So I think the first step is really paying attention to what the data is telling us in terms of, you know, developing our interventions, our approaches, our engagement strategies. I think a lot of times we forget that the data tells a story. And, you know, like, for instance, as a whole county, we look not great in terms of disparity, but it's even worse when you look at different, what I mentioned were service areas. And so when we took notice of that, like, we looked individually at the data at the local level, we found out, for example, like the East San Gabriel Valley area, it's a service area that I used to be the chief over. And they have about 549 people in FSP in that service area. It's like 435 square miles. It's, you know, 1.9 million people. So 26% are API or identify as API, but only 10% of our FSP population were API. And so, you know, being able to pay attention to what the data is telling us can help us shape then how we change our interventions. Like, we shifted around some of the funding for FSP to go towards API dedicated programming, which we had very little of in the service area. And then, you know, also, like, for instance, in one of our other service areas, we had a very large African-American population in FSP. So we did a great job in terms of penetration rate. But then when we looked at the data, we found out the outcomes were not good. So we were getting people in and they were staying in FSP, but we weren't getting the outcomes we were really hoping for in terms of, especially homelessness and incarceration. So then how do we then, you know, let that shape what we do, what our approach is, the kind of training we give our teams, the kinds of interventions and models that we put forward. So I think that's how it's connected. Like, first you have to pay attention to what you're looking at and then translate that to how we're going to use it to address disparities.
Thank you, Lisa.
Dante, can I just add on just a little bit?
Yeah, please do.
That I think another thing that we also need to pay attention to from a data perspective is what is the number, right? When we're talking about disparities across our different communities, what is the comparison group? Right? When you're talking about disparities, are you comparing across races? Are you comparing at your county level to census data and then extrapolating from that this certain percentage is represented in your county and therefore this certain percentage should be represented in your receiving specialty mental health care, right? And so really understanding the population and what the unmet need really is, because as we know with equity, it is not equal. Right? And so really fully understanding that when you look across your FSP programs, if you have a higher representation by certain community, even if they're represented more in your FSP, maybe that's appropriate, right? And so actually understanding unmet mental health need and what disparities actually means within your counties.
Yeah, very important, because we found there was a big difference in the data between the potential Medi-Cal recipients, who would be the people who utilize our services, versus just the general census population.
And we have currently a dashboard up in which we don't call it disparities. I was very intentional about not calling it disparities because it's a reflection of what's the census data in your counties across the state in demographics, what's those who qualify for specialty mental health care, and then what's CSI demographics and what's FSP demographics. That is not disparities, right? That is a step in trying to understand differences, but definitely not how we're addressing disparities.
Thank you both. Love the dialogue that we are creating here. We only have a few more minutes left, so I'm just going to ask one final question before I wrap us up today, and I'll open this up to the full group. Can you speak more to the specific outcomes you target and the process by which they were developed? More broadly, it would be interesting if anyone could speak to the balance between measurable quantitative outcomes and qualitative cultural understanding.
I can take that if we want. I'll take it. So just to make sure, Nicole, that I'm understanding. So you're saying the balance between quantitative and qualitative, basically, I think is what the question is, right? In my mind, although it can be really difficult to actually collect qualitative data, right? Because it's a lot of narrative data. How do you really boil that down, right, into some sort of standard reporting tool? But I actually think that qualitative data is where the richness happens and where you really fully understand the impact that services are having. We heard from Stafford, and we heard Stafford's story of this is what FSPs have done for my life, and this is the services that I'm receiving and why it's important to me. And it's hard to capture what I call the richness and the true story of the impact in a quantitative fashion. And so what we try to do, and again, it's very difficult, and I don't necessarily know if we've done it well quite yet at the commission, but really try to capture the stories and then have that inform our questions, how we are looking at the data, and then also what we're reporting.
I so value what Dr. Early just shared. I really think that too often we're kind of seeing, as this dichotomous choice of quantitative versus qualitative, when really, both can inform each other. And when we find that we talk to clients about their experiences, we find that the data that we get is not adequately capturing what their experience is. So I know it's a ton more work and it takes a lot more time, but what we've done with some client surveys that we've had, we actually give a qualitative section and we have to break it down into a content analysis, which is like really time consuming, but gave us some very rich information that was actually quite different from what the quantitative data was telling us, especially around what's important to clients, what's meaningful to them.
So true. Thank you all so much. What a wonderful panel that we have had today. I will just do a couple of quick notes to wrap us up. Thank you all for joining us. We're so thrilled that you could be here, both panelists and attendees, to hear about the Multi-County FSP Innovation Project and all of the different ways that some of the participating counties, LA counties, and their partners are working to drive equitable services and outcomes across the state. Really quick plug, if what you heard today piqued your interest, we're actually working on starting a next cohort of counties to join this innovation project over the summer. So this cohort will serve as a wave 2, if you will, and build off all of the work that Fresno, Sacramento, San Bernardino, San Mateo, Siskiyou, Ventura, and LA have done to date, continuing to leverage data to improve FSP programs and building up an even stronger statewide collaboration with other partners like the MHS OAC. Stanislaus is committed to joining, and we'd love to have another diverse cohort. So if you're interested in joining, learning more, or if you have any questions about the project or the webinar, you can feel free to reach out directly to Aurel and myself. Our emails are on this slide. You can also always find more information about the project and updates at thirdsectorcap.org/multi-county CAFSPN, including a recording of our first webinar that was part 1 of this series that can also be found on the website. Everyone that attended today will be receiving a copy of the materials that we presented, a recording of the session, and a newly released project progress report that summarizes the goals, the challenges, the successes, and the lessons learned from the multi-county FSP cohort to date. So thank you. I'm sorry that we could not get to all of your questions. If you did pose a question that we didn't get to, feel free to follow up via email, and I can see what our panelists can do to get you an answer. Really appreciate everyone's time today. Thank you, and have a good rest of your day.